Hello, today we're going to talk about the lower limbs, and we're going to start by talking about the thigh and the gluteal regions. So the gluteal region and the lower limb is basically an extension of the trunk. It's going to be specialized for locomotion and balance, and there's 6 major regions. Today we're just going to be talking about 2 of those. There's the gluteal region, which is the buttocks and hip, the femoral region, which is the thigh, the knee, the leg, which is the calf or the shin, the ankle, also called the talocrural region, and the foot. Let's just talk a little bit about the arrangement of the lower limb bones. First of all, your body weight is transferred from that vertebral column to the sacroiliac joint, which is between the sacrum and the ilium of the pelvis. And then it's transferred to the pelvic girdle, and then will be transferred to the limb. The leg in the thigh area is called the femur. It's at an oblique angle, kind of inferior and medial, and it returns to the center of gravity in order to support the legs and the feet. We're going to see later that the femurs in females are more oblique, so they have a greater angle than in those of males. So that helps the female to have a greater pelvic width, which helps her for childbearing. At the knees, the distal femur articulates with the patella and the tibia. The weight is transferred from that knee joint to the ankle through that tibia. And the smaller bone on the lateral side of the leg is called the fibula, and that does not articulate with the femur, so it doesn't even contribute to the ankle joint. At the ankle, the weight of the tibia gets transferred to the talus. We'll talk about that bone. It's a keystone of the longitudinal arch of your foot, where your metatarsals are, that help to create a stable platform to support the body. The hip bone is also called the os coxae. It's made up of 2 coxal bones. Each coxal bone is made up of 3 separate bones, the ilium, ischium, and pubis. Those 3 bones fuse by the age of 20, and they originally are joined by a hyaline cartilage, and then they fuse, and the fusion usually is complete by age 25. So they start at about 20, and then they're completely fused by the age of 25. The medial aspect of the pelvis we'll talk about more when we get to the perineum lecture. The ilium is the largest part of the hip bone, and it forms the superior aspect of the acetabulum, which is the socket that the head of the femur sits in. There is a thick medial portion for weight bearing, and then there's more of a thin posterior and lateral portion called the ala, which is used for attachments, for bone attachments. At the front, there is a projection that's called the ASIS. So they are right here. Those are kind of those bony projections that you feel on the front of your hip. And they're also one just a little bit lower that's a little bit harder to see, that's called the AIIS, or the anterior inferior iliac spine. And both the ASIS and the AIIS provide muscle attachments sites. On the anterior aspect of the ilium, there is the iliac fossa that's an indentation. This indentation, this fossa, might become thin and translucent, where you can almost see through it, with people that have osteoporosis. On the posterior aspect of the ilium, you can see the iliac crest as it extends posteriorly, and it ends at this area that we call the posterior superior iliac spine. And just inferior to that is the posterior inferior iliac spine. The posterior inferior iliac spine marks the superior end of the greater sciatic notch. So you can see the greater sciatic notch right here. And over here, you can see a better picture of it right there. So as the name implies, that's where the sciatic nerve travels through before going to the leg. The ala of the ilium is just this huge expanded area of the bone. And within this ala, there are these gluteal lines. So here you can see the posterior gluteal line. Here we have the anterior gluteal line, and then here you have the inferior gluteal line. So these are attachment sites for 3 large gluteal muscles. The iliac tubercle, or otherwise known as the tubercle of the iliac crest, is found on the superior aspect of the ilium. Let's take a look at the ischium. The ischium is the posterior and inferior part of the hip bone. The ischium fuses superiorly with both the pubis and the ilium, forming the posterior and inferior aspect of the acetabulum, or of that hip socket. It forms the ischiopubic ramus, where it extends anteriorly. It also forms the greater sciatic notch on an inferior margin, which is a deep indentation. The lesser sciatic notch is inferior to that, and that's used as a pulley for a muscle or for muscles. The ischial tuberosity is the sit bone, where the body's weight rests when you're sitting, and it's also an attachment for the thigh muscles. The pubis forms the anterior medial part of the hip bone. The pubis forms the anterior part of the acetabulum, or hip socket. It is the proximal attachment site for muscles of the medial thigh, which are the adductors. The pubis is divided into a body, a superior ramus, and an inferior ramus. The anterior and superior border forms the pubic crest. The pubic tubercles are the landmarks in the inguinal regions on the pubis. The obturator foramen is a large oval or triangular opening in the hip bone that's bound by the pubis and the ischium. It's closed by a thin membrane that offers a small passageway for obturator nerves and blood vessels, and that opening is called the obturator canal. The acetabulum is the hip joint. Acetabulum is a word that's Latin for a shallow vinegar cup. The acetabulum is a large cup-shaped cavity or socket that articulates with the head of the femur and forms the hip joint. The acetabulum is incomplete on its inferior border, and we call that area the acetabular notch. The floor of this acetabulum, or the floor of the acetabular fossa, is a rough depression, and it articulates with the head of the femur, which has a very smooth surface. Let's talk about the anatomical position of the hip bone. So we know the anatomical position of the body is if you're facing forward with your palms forward and your feet forward about shoulder width apart, but the hip bone also has an anatomical position. So in this position, the ASIS, or the anterior superior iliac spine, and the anterior aspect and the anterior superior aspect of the pubis would be in the same coronal plane. So the ASIS would be tipped forward and would be at the same anterior position that pubis would be in. The symphysis surface of the pubis is vertical and is parallel to the median plane. Once in the anatomical position, the acetabulum faces inferior and laterally, and the obturator foramen lies inferior and medial to the acetabulum. The internal aspect of the body of the pubis faces almost directly superior in order for the urinary bladder to rest on it. The pelvic inlet is the superior pelvic aperture or opening, and it's more vertical than horizontal with the tip of the coccyx near its center. The femur is the thigh bone. It's the longest and heaviest bone in the body. It transmits body weight from the hip bone to the tibia when standing. The length of the femur is approximately 1/4 of a person's height. At the proximal end of the femur, there is the head, the neck, and the 2 trochanters, the lesser trochanter and the greater trochanter, and then the shaft. The head of the femur is round, and it's covered by an articular cartilage. At the center of the head is a medial depression or pit that's called the fovea, and that is an attachment site for the ligament of the head of the femur. The neck then is continuous with the shaft of the femur. At the proximal end of the femur, we see the angle of inclination. The angle of inclination is 0 at birth, but then gradually becomes more acute until adulthood, where it's around 115 to 140 degrees, and it averages about 126 degrees in an adult. This angle is less in females due to the increased width between the acetabulum and of the right and the left side that is there to adapt for childbearing. The adductors and the rotators attach to this greater trochanter. The angle of the inclination between the neck and the shaft allows for the abduction to be more lateral than vertical. And this makes it easier for walking, but it also puts a strain on the neck of the femur. And this can be a problem in elderly when their bones are less dense to begin with. The angle allows the knees to be adjacent and inferior to the trunk, and this helps to allow for weight bearing. The trochanters are formed by the union of the femoral neck and the shaft. The lesser trochanter extends medially, and the iliopsoas muscle attaches there. The greater trochanter is more lateral. It projects superior and posteriorly where the neck joins the shaft, and it's the attachment for the abductors and the rotators of the thigh. The neck and the shaft join at the intertrochanteric line, which is an attachment site for the iliofemoral ligament. The shaft of the femur is slightly bowed or convex anteriorly. A disease called rickets may weaken the shaft, and then the bowing is exaggerated. Rickets is caused by a vitamin D deficiency and can cause bow-leggedness. The linea aspera is a broad, rough line for attachment of the thigh adductors that is on the shaft of the femur. At the distal end of the femur, there are the supracondylar lines that lead to the medial and lateral femoral condyles. The medial and lateral femoral condyles make up almost the entire distal end of the femur. In the anatomical position, the medial and lateral condyles are in the same horizontal plane. The condyles articulate with the menisci. The menisci are crescent-shaped plates of cartilage in the knee joint. There's a medial meniscus and a lateral meniscus. The menisci and the tibial condyles glide as a unit across the femoral condyles during flexion and extension. The condyles are separated by an intercondylar fossa. They merge anteriorly to form the patellar surface that articulates with the patella. The lateral surface of the lateral condyle is the lateral epicondyle, and the medial surface of the medial condyle is the medial epicondyle. The adductor tubercle is on the medial epicondyle, and it is the location for adductor muscle attachments. The lateral epicondyle is the attachment site for the lateral collateral ligament, otherwise known as the fibular collateral ligament, and the medial epicondyle is the attachment site for the medial collateral ligament, otherwise known as the tibial collateral ligament. For surface anatomy, you can see the iliac crests, and you can palpate the iliac crest by putting your hands on your hips. You can palpate the anterior superior iliac spine, which is the rounded anterior end of the iliac crest. You can palpate the iliac tubercle, which is just posterior to the ASIS. On the posterior side, there's the PSIS, which is at the bottom of the skin dimple. So sometimes you can feel this, and sometimes it's difficult to palpate, but it's easy to locate because of the dimple. The dimples are also where the iliac crests terminate. Swelling in this area or edema is evident because the dimple disappears. So if you are standing in front of someone, you can put your fingers on top of their iliac crest and drop your thumbs down, and you should be right on top of the anterior superior iliac spine, or the ASIS. If you move your fingers superiorly and posteriorly, you'll then be able to feel the tuberculum of the iliac crest, or the tubercle of the iliac crest. The pubic tubercle is 2 centimeters lateral to the pubic symphysis. The ischial tuberosity is the inferior part of the buttocks when the legs are bent. You'd be able to palpate that. And you can also see the gluteal fold, which is the separation of the buttocks and the thigh. The center of the femoral head is 1 thumb breadth inferior to the midpoint of the inguinal ligament. The greater trochanter is superior to the shaft of the femur, is lateral to the thigh because of that angle, is about 10 centimeters inferior to the iliac crest, and is basically uncovered when not non-weight bearing. So there's no muscles around that area. However, there might be some fat and adipose tissue in that area. The femoral condyles can be palpated when the knee is flexed. They're on the distal end of the femur. And the femoral epicondyles are just lateral to that, so they're the lateral aspect of the condyle. The patella is the kneecap, and it slides during flexion and extension of the knee joint. And you can also feel the adductor tubercle, which is on the medial aspect, the medial and superior aspect of the medial condyle. So if you push your thumb inferiorly along the medial side of the thigh, as soon as you get to that bump, you'll be able to feel it. So the patella is a large sesamoid bone. A sesamoid bone is a bone that's formed in a tendon. So the patella is formed in the tendon of the quadriceps muscle after birth. The patella articulates with the patellar surface of the femur that's formed by those menisci. The anterior surface of the patella is concave, and the posterior surface is an articular surface that's covered with articular cartilage. The medial and lateral side of the anterior surface is divided by a vertical ridge. The patella is balanced by the pull of the vastus muscles, and the ridge keeps the patella centered in the middle of the knee. Knee, leg, and foot injuries are the most common lower limb injuries. Hip injuries make up less than 3% of lower limb injuries. Adolescents are most vulnerable to lower limb injuries because of sports and overuse. In adolescence, the growth plates are still there, so they're still visible, and ossification of these bones, and these bones would go through endochondral ossification. It's not complete until early adulthood. Bones grow faster than attached muscles do during development, so this plus sports could result in irritation and injury to the growth plate and the developing bone, as the muscles are shorter than what they should be because the bones have been growing faster. Here are some examples of pelvic fractures. So there could be a fracture of the ilium, ischium, or pubis. Hip fracture is actually misnamed because it is commonly applied to fractures of the femoral head, neck, or trochanters, and the hip is really the ilium, ischium, and pubis. So here you can see in the pubic bone, you can see a pelvic fracture. There's also another one in the ilium. And then over on B here, you can see that there is a fracture of the neck of the left femur. Avulsion fractures of the hip bone occur where the tendon pulls away from the bone. So we see this on the ASIS, on ischial tuberosities, and on the ischiopubic rami. Right here, what you can see is that there's a pulling away at that ischial tuberosity where that tendon is being pulled away from the bone. And that's going to be from, in this case, someone looks like they're doing some hurdling. And so down here in the x-rays, you can also see the avulsion fracture of the adolescent pelvis. Again, the angle of inclination is that angle between the femoral neck and the shaft. This angle is going to vary with sex or age or even development of the femur, so there's some congenital components. The angle might change with pathology. Coxa vera is a condition when the angle is decreased, and coxa valga is when the angle is increased. Vera means that the shaft will deviate towards the midline because the angle has been decreased, and so the shaft is going to move medially towards the midline. The femur is shortened and abduction is limited then because it's harder to pull that bone vertically than it is horizontally. In valga, the shaft deviates away from the midline. Fractures of the female are common and are a lot of times age and sex related. Fractures of the femur occur most frequently in the narrower neck region, and it's definitely more vulnerable with age and osteoporosis. Here you can see a diagram of the femoral fracture, and then over here you can see an x-ray of the femoral fracture too. You can see that radiolucent line indicating a fracture. Femoral fractures might occur in the middle of the neck, or they can even occur in the intertrochanteric area. The fractures are unstable and impaction can occur if the segments override each other. This plus muscle spasm in the area might lead to a shortening of the limb. Fractures of the greater trochanter and shaft result from direct blows or falls, which are common during active years. So when a person is skiing or climbing and they fall, or maybe even during a motor vehicle accident. Spiral fractures or comminuted fractures where there's fragments may take up to a year to heal. Fractures of the distal femur can be complicated by a separation of the condyles. This can cause a misalignment of those articular surfaces of the knee joints, or it can cause a hemorrhage of the popliteal artery, which is very close to that area. Always consider the compromise of blood supply to the leg with any distal femur fractures. At the knee, the subcutaneous tissue loses its fat and it's going to blend in with the deep fascia. The deep fascia of the lower limb is especially strong, and it wraps the leg kind of like an elastic stocking. This is going to limit the outward expansion of contracting muscles, and so it's efficient in compressing the veins and helping to push the blood back towards the heart. So we call this the muscular pump, when skeletal muscles compress and squeeze on the veins and they help to push that blood up back towards the heart. The deep fascia also helps to keep any infections kind of localized to certain compartments that the deep fascia is wrapping around. The deep fascia on the thigh is called the fascia lata. It encloses the large thigh muscles, especially laterally, and also laterally it's thickened and strengthened by additional longitudinal fibers, and it forms what we call the iliotibial band. The iliotibial band extends from the iliac tubercle to the anterolateral tubercle of the tibia. The thigh muscles are separated into three compartments: the anterior, medial, and posterior compartments that are formed by the fascia lata. There are superficial veins and deep veins in the lower limb. The two major superficial veins in the lower limb are the great saphenous vein and the small saphenous vein. The great saphenous vein is formed by the union of the dorsal vein of the great toes and the venous arch of the foot. The great saphenous vein empties into the femoral vein, and then the femoral vein empties into the external iliac vein. The greater sciatic vein contains 10 to 12 valves, and these valves prevent backflow of blood in the extremities. The popliteal vein is a deep vein. The anterior tibial vein, posterior tibial vein, and fibular vein drain into the popliteal vein posterior to the knee, and then the popliteal vein becomes the femoral vein at the knee. Blood flow is slower when standing quietly, and the muscular pump will push that blood back to the heart, like I explained in a previous slide. There's both superficial and deep lymphatic drainage in the thigh as well. There are superficial inguinal lymph nodes and also deep inguinal lymph nodes. These inguinal lymph nodes pass directly into the external iliac lymph nodes. The popliteal lymph nodes are also superficial lymph nodes, and they surround the popliteal vein. Then there are deep lymphatic vessels that also enter the popliteal lymph nodes, and then they're going to ascend to the deep inguinal lymph nodes. From there, from the inguinal lymph nodes, lymph will flow to the external lymph nodes and common iliac lymph nodes, and then to the lumbar lymphatic trunks. From the lymphatic trunks, then lymph will flow into the cisterna chyli and then into the thoracic duct to the left subclavian vein. The dermatome mapping of the lower limbs, again, is preferred by using the Forster mapping clinically. So L1 will be supplying the inguinal area. L2 spinal nerve supplies the antero-superior thigh. L3 supplies the antero-inferior thigh. And L4 supplies the medial leg. And S1 supplies the lateral foot and the dorsal foot, but not the first three digits. S2 will supply the posterior thigh, and S3 will supply the peripheral buttocks. Cutaneous innervation of the lower limb is from cutaneous peripheral nerves. So the cutaneous nerves supply skin of the lower limb, but there's going to be more than one spinal nerve involved in these cutaneous nerves. The cutaneous nerves arise from the lumbar and the sacral plexuses. So here are the cutaneous nerves from the lumbar plexus that I want you to know. The subcostal nerve is the nerve from the hip to the anterior iliac crest and the greater trochanter. The ilioinguinal nerve is monitoring the medial femoral triangle. The genitofemoral nerve is monitoring the lateral femoral triangle and the anterior scrotum in the males, or the labia majora in the females. The lateral cutaneous nerve of the thigh innervates the anterior and lateral aspects of the thigh. The anterior cutaneous branches of the femoral nerve innervate the anterior and medial aspects of the thigh, and the cutaneous branch of the obturator nerve innervates the middle part of the medial thigh. The cutaneous nerves of the sacral plexus that I want you to know are the posterior cutaneous nerve of the thigh that supplies the posterior thigh in the popliteal fossa, the saphenous nerve, which supplies the medial side of the leg and the foot, the superior cluneal nerves, which supply the superior and central part of the buttocks, the medial cluneal nerves, which supply the medial buttocks and the intergluteal area, and the which you can see on this picture, but this one's actually part of the lumbar plexus, the iliohypogastric cutaneous nerve, which is on the superior and lateral quadrant of the buttocks. So it's supplying the superior and lateral quadrant of the buttocks. Again, it's on this posterior picture. It's not on the anterior picture, but it's from the lumbar plexus, not the sacral plexus. So that's it for sensory. When sensory is the dermatome and the cutaneous innervation. Now we're going to look at motor innervation of the lower limb. And the lower limb muscles are going to receive motor fibers from several different spinal cord segments, in other words, from several different spinal nerves. And that's called a myotome. And most muscles are composed of more than one myotome. So there are multiple cord segments that are involved in producing movement of the lower limb. You should know these different movements and what are the spinal nerves that are involved with the movements. So when we look at the hip flexion is L2 and L3, extension is L4 and L5, abduction occurs because of innervation from L5 and S1, adduction occurs because of innervation from L2, 3, and 4, which is the femoral nerve. Medial or internal rotation is from L4 and L5, and lateral or external rotation is from L5 and S1. With the knee flexion is due to L5 and S1 innervation, and extension is due to L3 and L4 innervation. Deep tendon reflexes are another diagnostic tool in checking the lower extremity and checking the nerve roots. So when you're testing the quadriceps muscle and you're taking the reflex hammer onto the patellar ligament, you're testing the L3 and L4 spinal nerve roots. And then we haven't talked about the leg or the lower part of the lower limb, but the calcaneal or the Achilles reflex, otherwise known as the ankle jerk. You are testing the S1 and the S2 spinal nerves. All right, so let's talk about a couple of clinical applications. There's a syndrome that's called the Compartment Syndrome, and this can be caused from trauma from burns or sustained intense use of your muscles. It can be caused from blunt trauma that's producing hemorrhaging. And what it causes is edema and inflammation that compresses the blood vessels and the nerves. And so when those blood vessels and nerves get compressed, then you have, first of all, the distal leg pulses will be reduced. And so a loss of distal leg pulses is an obvious sign of compartment syndrome. And because the blood vessels are not delivering blood, there will also be lowered temperature of the tissues distal to wherever the compression is. So the treatment for this is a fasciotomy, where they will take and do an incision over the overlying fascia, and that will help to relieve the pressure. Varicose veins is another condition that I want you to know about. Varicose veins are kind of common. They frequently happen in the great saphenous vein and the tributaries of the great saphenous vein. And so what happens is these veins, the great saphenous vein and the tributaries become really dilated, and then the valves can't close because they're too far, the two sides of the valves are too far apart. So this is common in the posterior part of the thigh and the lower limb, and also the medial lower limb. Varicose veins cause a lot of discomfort. A deep vein thrombosis, or a DVT, occurs in the deep veins, and they normally occur in the leg, although you can get DVTs in the arms as well. It's just a lot less common. And so in the leg, a person will have swelling and warmth and redness from the inflammation. And a lot of times this occurs if a person is sitting for too long of a period of time. So if they're on a long flight, or if they're driving in a car halfway across the country, DVTs can be they'll be more susceptible to it. So in this case, a thrombus forms and then breaks away, and it could travel to the lung, in which case we call it a pulmonary thromboembolism, and this is very dangerous. It can cause death. There's another thing too, the saphenous vein grafts. The great saphenous vein can be used as a transplant for coronary arterial bypass. The great saphenous vein is really muscular and elastic, and there is a much greater distance between tributaries in the great saphenous vein, so they don't have to worry so much about little openings and other veins leading away from the great saphenous vein. So it's a lot easier to use in coronary arterial bypass. Not as many holes, basically. Other deep veins will drain the lower limb if the great saphenous is removed. So it's also not that big of a deal to be able to remove that great saphenous vein, because other veins will pick up that drainage of blood. Enlarged inguinal lymph nodes are also a condition I'd like you to know. So lymph nodes, basically, they enlarge when they get diseased. Lymph is flowing through those lymph nodes, and the lymph nodes have T cells and B cells in them. And when there's any type of abnormal cell or bacteria or pathogen, then the T cells and B cells start to proliferate, and then the lymph nodes have to get larger in order to handle all of those, that increased number of cells. And so those enlarged lymph nodes then are pretty easy to palpate. From females, if there's enlarged inguinal lymph nodes, you start to suspect possibly a metastatic cancer from the uterus. So I had mentioned the difference between dermatomes and cutaneous nerve and their distribution. And so when you're examining just spinal nerves, like individual spinal nerves, you're looking for sensory function in the dermatomes. But when you're examining peripheral nerves, you're looking for sensory function in cutaneous nerve distribution, because peripheral nerves have more, there's more than one spinal nerve usually contributing to that peripheral nerve. So you're looking for sensory function in multiple spinal nerves. Pain sensation is tested by using a sharp object and then asking the patient if pain is felt. So you're using like a pinwheel and asking, do you feel this? Do you feel that? And you're just looking for sensation. If there's no sensation, the spinal cord segment and or the peripheral nerve that's involved can be determined. So now we're going to start to look at the muscles of the lower limb, of the proximal lower limb, which is the thigh area. And abductors of the thigh are in the lateral gluteal region, and the remaining thigh muscles are organized into three compartments: anterior or extensor, medial or adductor, and posterior or flexor. The anterior thigh muscles contain the flexors of the hip, and they include the pectineus, the iliopsoas, the sartorius, and the quadriceps muscles. The pectineus muscle is flat and quadrangular in the anterior thigh. They're kind of superior and medial. The origin is the superior ramus of the pubis, and it inserts on the pectineal line of the femur, just inferior to the lesser trochanter. The pectineus is innervated by the femoral nerve, which is L2, L3, and maybe even a branch from the obturator nerve. The action of this muscle is to adduct and flex the thigh. It also assists with medial rotation of the thigh. The iliopsoas is the chief flexor of the thigh. It is the most powerful of the hip flexors with the most range. You find the iliopsoas in the posterior wall of the abdomen and the greater pelvis. There's two parts to the iliopsoas. There's the psoas part that's medial, and the iliacus, which is lateral. The iliopsoas is the only muscle that's attached to the vertebral column, the pelvis, and the femur. The iliopsoas contributes or perpetuates a disability or deformity if it's malformed. So if it's shortened or if it's dysfunctional, it contributes to disability. Meaning that this is a pretty important muscle, and if there is a problem with it, if it is shortened or if it is dysfunctional, a person will have a disability and maybe not be able to walk, or will walk with a bent or with a limp. The iliopsoas initiates the forward swing when walking. It also initiates elevation when climbing, so picking your leg up to climb. The iliopsoas contracts bilaterally when doing sit-ups incorrectly. So when not curling up, but instead just coming up flat backed. The iliopsoas resists acceleration when walking downhill, and it maintains a normal lumbar lordosis when standing. So let's look at origin, insertion, innervation, and action. The psoas major originates on the side of T12 to L5 vertebrae and the discs in between them, as well as the transverse processes of all the lumbar vertebrae. And then it inserts into the lesser trochanter of the femur. The psoas major is innervated by the anterior rami of the lumbar nerves, L1, 2, and 3. The psoas major acts as it works with the psoas minor and the iliacus to flex the thigh at the hip and to stabilize that joint. It is a postural muscle that controls the deviation of the trunk during standing. The psoas minor originates at the sides of T12 to L1 vertebrae and the intervertebral discs. It inserts on the pectineal line and the iliopubic eminence. It is innervated by the anterior rami of the lumbar nerves, L1 and L2, and its action is to work with the psoas major and the iliacus to flex the hip, to flex the thigh at the hip, and to stabilize the joint. The iliacus is the portion of the iliopsoas muscle on the iliac bone. So it originates on the iliac crest, the iliac fossa, the ala of the sacrum, and the anterior sacroiliac ligaments. It inserts on the tendon of the psoas major, the lesser trochanter, and the femur just distal to the lesser trochanter. The femoral nerve, L2 and L3, innervate the iliacus muscle. And again, I'm not going to have you, you're not going to have to tell me, memorize what specific spinal nerves are innervating each specific muscle, but you would have to tell me, for instance, that the femoral nerve is L2, 3, and 4. But you wouldn't have to tell me that specifically the femoral nerve, L2 and L3, branches of the femoral nerve innervate the iliacus. The action of the iliacus is that it works with the psoas major and minor to flex the hip, to flex the thigh at the hip, and to stabilize the joint, just like the psoas major and minor do. So here I'm showing the sartorius, and I had to superimpose a picture over another picture here, so I hope you can see this, but the sartorius is the longest muscle in the body. It's very long and ribbon-like. It will weakly abduct and laterally rotate the thigh. It is a weak muscle, so it usually acts as a synergist rather than an agonist. So it's not really a prime mover. It helps another muscle, helps other muscles. The sartorius brings the lower limb into that cross-legged position, and that's kind of where its name comes from. So sartor is Latin for tailor, and so it produces the 4 actions that help to produce the cross-legged position that were used by tailors as they sat on the floor and were tailoring men's pants. So the origin of the sartorius is on the ASIS, and it's also on the top notch just below the ASIS. It crosses over the thigh medially, and then it inserts on the superior part of the medial surface of the tibia. So it's going to cross 2 joints then. It crosses the hip joint, and then it's going to cross the knee joint. It's innervated by the femoral nerve, and its job is to flex and abduct and laterally rotate the hip. Because it's also crossing the knee joint, it can also flex the knee, or work as a synergist to flex the knee, and to medially rotate the hip when the leg is flexed. So it just depends on what the position of the knee is. If the knee is extended, then it will help to laterally rotate the hip. But if the knee is bent, then it will work to medially rotate the hip. So now we're going to look at the anterior thigh muscles, which are the extensors of the knee. So they extend the knee. They are made of the quadriceps muscles. The quadricep muscles cover all of the anterior aspect and the sides of the femur. The quadriceps are the largest and one of the strongest muscle groups in the body. So they are called the great extensor of the leg. They're important during rising from sitting or squatting. They're important in climbing and walking upstairs, and in acceleration and projection, which is running and jumping. The quadriceps muscles include the rectus femoris, the vastus lateralis, the vastus medialis, and the vastus intermedius. At the distal end of the quadriceps, the tendons from the quadriceps femoris muscles form the quadriceps tendon that attach to the patella. Then that tendon continues past the patella as the patellar ligament, which attaches to the tibial tuberosity. So let's start by looking at the rectus femoris. The rectus femoris runs downhill, it runs straight. Rectus is Latin for straight. So the rectus femoris crosses two joints. It's going to cross the hip joint, and then it's going to cross the knee joint. So it will flex the thigh and it will extend the knee. It acts like the iliopsoas during the pre-swing of walking and initiates that swing phase of walking. So it's involved in the initial swing phases of walking. The rectus femoris is efficient in combining both knee extension and hip flexion. For example, like when you're getting into position to kick a soccer ball. This rectus femoris is susceptible to avulsion from the anterior inferior iliac spine when kicking. So this muscle is oftentimes called a kicking muscle. The origin of the rectus femoris is the anterior inferior iliac spine and the ilium superior to the acetabulum, and it inserts on the quadriceps tendon. So it's directly inserted onto the base of the patella, and it's also indirectly inserted onto the patellar ligament, which is a little less stable. It also inserts onto the medial and lateral patellar retinaculum, which is medial and lateral to the tibia and the patella. It's innervated by L2, 3, and 4, which is the femoral nerve. And its action is to extend the knee and to steady the hip joint. And it also helps the iliopsoas flex the thigh. The vastus lateralis is the largest of the vastus muscles. There's three vastus muscles, the lateralis, the medialis, and the intermedius, and it's difficult to isolate any of the vastus muscles. Although there are some exercises that help to, kind of isolate the vastus medialis, which tends to be the weakest of them. But the origin of the vastus lateralis is the greater trochanter and the lateral lip of the linea aspera of the femur. The insertion is the same as what the rectus femoris was. The innervation of the vastus lateralis is the femoral nerve, and the action of the vastus lateralis is to extend the knee. The origin of the vastus medialis is the intertrochanteric line and the medial lip of the linea aspera of the femur. It's on the medial aspect of the thigh, and its insertion then will be the same as the rectus femoris and the lateral, the vastus lateralis. It also is innervated by L2, 3, and 4, and its action is also to extend the knee. The vastus intermedius is deep to the rectus femoris. Its origin is the anterior and lateral surfaces of the shaft of the femur, and it inserts on the same quadriceps tendon. It's identical to the other vastus muscles as well as to the rectus femoris, also innervated by L2, 3, and 4, and also its action is to extend the knee. The articularis genu muscle is another muscle that's in the knee area. It's an articular muscle of the knee. It's derived from the vastus intermedius. And so the articularis genu pulls on the synovial membrane surrounding that knee joint to prevent it from being compressed between the femur and the patella during extension of the leg. So it helps to prevent that synovial membrane from being pinched in between the femur and the patella when that leg is extending. The major muscles that I just went over of the anterior compartment tend to atrophy pretty rapidly with disease. So physical therapy is necessary to restore the strength, tone, and symmetry with the opposite limb after immobilizing the thigh or the leg. So after a surgery or after casting where the thigh or the leg has been immobilized, then physical therapy is necessary in order to restore that strength. Now we'll look at the medial thigh muscles. These are the adductor muscles. The adductor group includes the adductor longus, the adductor brevis, the adductor magnus, the gracilis, and the obturator externus. These muscles attach to the pubic bone, to the ischiopubic ramus, and to the ischial tuberosity. They also attach to that obturator membrane that covers the obturator foramen and the linea aspera of the femur. The adductor longus is a large fan-shaped muscle that is the most anterior of all the adductors. It covers the adductor brevis and the middle of the adductor magnus. It originates on the body of the pubis, just inferior to the pubic crest, and then it inserts on the middle third of the linea aspera of the femur. It's innervated by the obturator nerve and by the branch of the anterior division, L2, 3, and 4. So basically it's innervated by the anterior rami of L2, 3, and 4. So the anterior rami of the femoral nerve. The action is to adduct the thigh. The adductor brevis is a short adductor. The obturator nerve splits into an anterior and a posterior division, and they pass on the opposite sides of the adductor brevis. The origin of the adductor brevis is the body and inferior ramus of the pubis, and it inserts on the pectineal line and the proximal part of the linea aspera. It's innervated by the obturator nerve as well as the anterior division of L2, 3, and 4. The adductor brevis will adduct the thigh and to some extent will flex it. The adductor magnus is the largest and most powerful and most posterior of the adductors. It is triangular in shape and it has two parts, an adductor and a hamstring part. The adductor part fans out to attach to the linea aspera, and the hamstring part is more tendinous, and it has a distal attachment to the adductor tubercle. For the origin, the adductor part originates on the inferior ramus of the pubis and the ramus of the ischium. Then, as far as insertion goes, the adductor part will insert on the gluteal tuberosity, on the linea aspera, and on the medial supracondylar line. And the hamstring part inserts on the adductor tubercle of the femur. As far as innervation goes, it's innervated by the obturator nerve and by branches of the posterior division. And the hamstring part is innervated by the tibial part of the sciatic nerve. So we're going to learn how the sciatic nerve is actually made up of two nerves. One of them is the tibial part. The gracilis is a long strap-like muscle that is medial and superficial. It's the weakest member of the adductors. It is the only adductor to cross the knee and the hip joint. It joins the sartorius and the semitendinosus muscles to insert on a common location, which is called the pes anserinus. This adds to the stability to the medial aspect of the extended knee. The gluteus maximus and the tensor fascia lata also do that on the lateral side, but the pes anserinus is going to add stability to the medial side. The gracilis originates on the body and the inferior ramus of the pubis, and it inserts on the superior part of the medial surface of the tibia. It's innervated by the obturator nerve, and its action is to adduct the thigh, flex the leg, and to help rotate the leg medially. The obturator externus is a flat, small, fan-shaped muscle that's on the superior and medial thigh. It passes under the acetabulum and the neck of the femur to the posterior greater trochanter. It originates on the margins of the obturator foramen and that obturator membrane. And then it goes behind the femur and it inserts on the trochanteric fossa of the femur. It's innervated by the obturator nerve, and its action is that it will laterally rotate the thigh and it steadies the head of the femur in the acetabulum. The pes anserinus, then, to see this again, it's where there's converging tendons from the gracilis, the semitendinosus, and the sartorius muscles, and they form a common tendon. The gracilis is a synergist in adducting the thigh, flexing the knee, and rotating the leg medially when the knee is flexed. And then it works with the other two pes anserinus muscles to add stability to that medial aspect of the extended knee. It's similar again to how the gluteus maximus and tensor fascia lata do that through the iliotibial tract on the lateral side. The main actions of the adductor muscle group are to pull the thigh medially, or adduction. The adductor longus, brevis, and magnus can do this when the thighs are abducted, so like standing on a balance board, or when adducted, like when you're riding a horse and the legs are adducted and still trying to pull the thigh medially. The adductor muscle groups are also used when kicking with the medial foot, like with soccer and swimming, or they help to stabilize the stance when you're standing on both feet. And they also contribute to flexion and extension when you're running against resistance. Let's look at an area in the upper thigh that's called the femoral triangle of the groin. So there is a triangular depression that's just inferior to the inguinal ligament when the thigh is flexed and abducted and laterally rotated. And in this area, this femoral triangle, we can find the borders, and the inguinal ligament is superior, the adductor longus is medial, and the sartorius is lateral. So those four things form the femoral triangle. The sartorius and the adductor longus cross at what we call the apex of the triangle. The iliopsoas is in the floor of the triangle. The roof is formed by fascia and skin and subcutaneous tissue, and the inguinal ligament acts as a flexor retinaculum. So with this femoral triangle, it's kind of what we call a retroinguinal space. It's an important passageway. The external iliac blood vessels become the femoral blood vessels in this passageway. And the passageway also contains the femoral nerve, the femoral artery and its branches, the femoral brain and its tributaries like the great saphenous and great profundus veins, and then the deep inguinal lymph nodes and the lymph vessels. Those are all found within the femoral triangle of the groin. The femoral nerve consists of spinal nerves L2, L3, and L4. It's the largest branch of the lumbar plexus. It passes deep to the inguinal ligament through the femoral triangle, and in the triangle it divides. The divisions supply the anterior thigh muscles, the hip and knee joints, and then the cutaneous anterior and medial side of the thigh. The terminal cutaneous branch of the femoral nerve is the saphenous nerve. The saphenous nerve supplies the antero-inferior skin of the knee, leg, and foot. So the anterior and inferior skin of the knee, leg, and foot. A femoral sheath covers the femoral artery and vein, and it allows them to glide without friction through the inguinal ligament. The external iliac artery becomes the femoral artery as it passes underneath the inguinal ligament and enters into the femoral triangle. You can palpate the femoral artery in the femoral triangle. The profundal femoris artery is a deep artery of the thigh that is the largest branch of the femoral artery and is the chief artery of the thigh. The femoral vein is the continuation of the popliteal vein. So the femoral vein becomes the external iliac vein at the inguinal ligament. The femoral vein is receiving different tributaries, and one of them is the profundal femoris vein, and the great saphenous vein is another one, and then there's a whole bunch of other tributaries as well. The adductor canal is a narrow passageway in the middle third of the thigh. It's about 15 centimeters, and it's from the apex of the femoral triangle. And it's an intermuscular passageway where the femoral artery and vein will go through, the saphenous vein goes through it, and it delivers those vessels to the popliteal fossa. The adductor canal is surrounded by the vastus medialis, the adductor longus, and the adductor magnus, and the sartorius muscle. There's some surface area that I want you to know in the thigh. 3 of the 4 parts of the quadriceps are visible, or they can be approximated. The vastus intermedius is underneath the rectus femoris, so we can't really see that. But the rectus femoris is observed as a ridge. You can lift the leg from sitting to see it better. The vastus lateralis and the medialis are large bulges at the knee, so you find those, the vastus lateralis just lateral and superior to the knee, and the vastus medialis just medial and superior to the knee. The patellar ligament is right below the patella, and that's where you would be doing the deep tendon reflex, the stretch reflex. The infrapatellar fat pads are on either side of the patellar ligament. You can measure the lower limb and compare it to the opposite side to determine if there's shortening of one side or the other. So you would measure the thigh and then compare it to the opposite side. And you measure the thigh by measuring from the ASIS to the distal edge of the lateral epicondyle. And a difference up to 1.25 centimeters may be normal between the right and the left side. The femoral artery runs from the inguinal ligament to the adductor tubercle while the thigh is flexed, abducted, and laterally rotated. So you can kind of follow the path of that femoral artery. The proximal third is in the femoral triangle, and the middle third is in the adductor canal. The femoral artery can be felt pulsating just below that inguinal ligament. And then just underneath that is the femoral head. The great saphenous vein enters the femoral vein about 3.75 centimeters inferior and 3.7 centimeters lateral to the pubic tubercle. So let's go over some clinical applications of the hip and the thigh. Contusions of the hip are called hip pointers, and this is a contusion of the iliac crest where the sartorius attaches to the ASIS. It's pretty common in collision sports like football, hockey, or volleyball. The sartorius or the rectus femoris might be avulsed, so you might have a avulsion of those muscles that could be involved. And there could also be on the thigh, if there's some type of a collision or a hit on the thigh, a thigh hematoma may occur in the quadriceps and cause a thigh Charlie horse. Something like that is usually from blunt trauma, like a hockey stick or a football. This picture is just showing the patellar tendon reflex. So the reflex hammer strikes the patellar ligament, and when you're doing that, the lower leg then kicks out, and you're testing the femoral nerve. We went over what a reflex was and how that happened. It's a monosynaptic or a monosynaptic reflex. An absent or a diminished patellar tendon reflex could be the result of the femoral peripheral nerve is either diseased or compressed somewhere. A groin pull is also known as a pulled groin or a groin injury by athletic trainers. It's a strain or a stretching or a tearing of the flexor and adductor muscles right at their attachments in the inguinal region. Causes a lot of pain right in the groin area. These groin pulls can occur whenever you're doing quick starts like sprinting or base stealing, and also in extreme stretching like in gymnastics. So palpating the femoral artery. The femoral pulse can be felt when the patient is supine, so face up, and you palpate midway between the ASIS and the inguinal ligament. So if you put your pinky on the ASIS and your thumb on the pubic tubercle, you could feel the femoral artery just below the inguinal ligament in the mid-palm area. The femoral artery pulse should be very strong. Compression of the femoral artery is used whenever you need to reduce blood loss, when you're trying to reduce hemorrhaging. So you would press that femoral artery up against the head of the femur. With angiography, this is where a catheter is placed. So the catheter is snaked up into the external iliac artery from the femoral artery, and then it'll go into the common iliac, and then to the aorta, and then to the left ventricle. Also in the femoral artery, blood can be taken from here to assess for arterial blood gases, so looking for bicarbonate and carbon dioxide and oxygen. The femoral vein is just medial to the artery, and the great saphenous vein is going to be tied off where it meets the vein if the great saphenous vein is going to be harvested for coronary bypass surgery. So I'm sure you've heard of hernias. Well, we're going to talk about a femoral hernia. The femoral ring is a weak area in the abdominal wall. It's about the size of a finger diameter. A femoral hernia is a protrusion of the abdominal viscera, or just a loop of the small intestine that protrudes from that area. It feels kind of like a mass in the femoral triangle. The femoral hernia will have to be surgically repaired, and it's important, and it can be very dangerous if the abdominal viscera, if the small intestine is strangulated. All right, now we're going to switch gears and we're going to go to the gluteal region, which is the buttocks and upper thigh region. And from the iliac crests to the gluteal fold, and from the greater trochanter to the anterior part of the ASIS is what we're going to be looking at, those areas. The intergluteal cleft separates the right gluteal region from the left gluteal region, and the gluteal muscles form the bulk of the region. They are the gluteus maximus, the gluteus medius, gluteus minimus, and the tensor fascia lata. The gluteal ligaments that are important in this area are the posterior sacroiliac ligament, the sacrotuberous ligament, and the sacrospinous ligament. So we're going to be looking at these structures. The greater sciatic foramen is an important foramen for structures entering or leaving the pelvis. For example, the sciatic nerve exits there. The greater sciatic foramen is a door through which arteries and nerves leave the pelvis and enter into the gluteal region. The piriformis muscle also enters the gluteal region through the greater sciatic foramen. There's also a lesser sciatic foramen, and the lesser sciatic foramen is an opening where structures entering or leaving the perineum would be found. For example, the pudendal nerve exits the lesser sciatic foramen. The muscles of the gluteal region have a common compartment, but they're in superficial and deep layers. The superficial layers of muscles in the gluteal region are the gluteus medius, maximus, minimus, and the tensor fascia lata. They all attach to the external surfaces of the ilium. They're mainly extensors, abductors, and medial rotators of the thigh. The deep layer of the muscles in the gluteal region are smaller, like the piriformis, the obturator internus, the superior and inferior gemelli, and the quadratus femoris. They all attach distally to the inferior half of the intertrochanteric crest of the femur. They are lateral rotators of the thigh, they stabilize the hip joint, and they steady the femoral head in the acetabulum. Let's take a look at these muscles individually. We'll start with the gluteus maximus. This is the large muscle in the buttock area. The gluteus maximus originates on the ilium posterior to the gluteal line. It also originates on the dorsal surface of the sacrum and coccyx, and it also originates on the sacrotuberous ligament. It inserts on the iliotibial tract, which inserts into the lateral condyle of the tibia, and some fibers insert on the gluteal tuberosity. It's innervated by the inferior gluteal nerve, and its action is to extend the thigh, mostly from the flexed position, and assist in lateral rotation, and to steady the thigh and assist in rising from a sitting position. The gluteus medius originates on the external surface of the ilium between the anterior and posterior gluteal lines. It inserts on the lateral surface of the greater trochanter of the femur. It is innervated by the superior gluteal nerve, and its action is to abduct and medial rotate the thigh to keep the pelvis level when the opposite side is weight-bearing, and it advances the unsupported side when walking. So it starts to swing that unsupported side forward when you're walking. Okay, let's take a look at the gluteus minimus. The origin of the gluteus minimus is the external surface of the ilium between the anterior and inferior gluteal lines, and then it inserts on the anterior surface of the greater trochanter of the femur. The innervation of the gluteus minimus is the superior gluteal nerve, and its action is that it abducts and medial rotates the thigh. It keeps the pelvis level when the opposite side is weight-bearing, and it advances the unsupported side when walking. Then we have the tensor fascia lata. The origin of this muscle is the ASIS and the anterior iliac crest. Then it inserts into the iliotibial tract, which attaches to the lateral condyle of the tibia. So you can see this long tendinous structure that's called the iliotibial tract, and the tensor fascia lata muscle is actually a lot smaller. The innervation of the tensor fascia lata is the superior gluteal nerve, and the action is that it abducts and medially rotates the thigh, keeps the pelvis level when the opposite side is weight-bearing, and it advances the unsupported side when walking. For the piriformis, the origin of the piriformis is the anterior surface of the sacrum and the sacrotuberous ligament, and then it crosses behind the ilium and pubis, and it inserts onto the superior border of the greater trochanter of the femur. It's innervated by the anterior rami of S1 and S2, and its action is to laterally rotate the extended thigh. It also abducts the flexed thigh, and it steadies the femoral head in the acetabulum. So this is another one where it depends on what the joint position is. So if the joint is extended, then it will laterally rotate the thigh. If the hip is flexed, then it will abduct the thigh. Then we have the obturator internus. The origin of the obturator internus is the pelvic surface of the obturator membrane and the surrounding bones, and then it inserts onto the medial surface of the greater trochanter, which is in the trochanteric fossa. The action of the obturator internus is to laterally rotate the extended thigh, abduct the flexed thigh, and steady the femoral head in the acetabulum. The origin of the superior gemellus is the ischial spine, and the origin of the inferior gemellus muscle is the ischial tuberosity. For the insertion, they both insert on the medial surface of the greater trochanter, which is called the trochanteric fossa. For the innervation, the superior gemellus is innervated by the same nerve supply as the obturator internus, and the inferior gemellus is innervated by the same nerve supply as the quadratus femoris. The action is that both of these muscles laterally rotate the extended thigh, abduct the flexed thigh, and steady the femoral head in the acetabulum. Then we have the quadratus femoris. The origin of the quadratus femoris is the lateral border of the ischial tuberosity. It inserts into the quadrate tubercle on the intertrochanteric crest of the femur and the area just inferior to that. It's innervated by the nerve to the quadratus femoris, and its action is that it laterally rotates the thigh and steadies the femoral head in the acetabulum. Now let's look at the posterior thigh region. 3 of the 4 muscles in the posterior thigh are the hamstrings, which are the semitendinosus, semimembranosus, and the long head of the biceps femoris. All 3 of these muscles attach proximally to the ischial tuberosity. They attach distally to the bones of the leg, so they span 2 joints, the hip and the knee, and they produce extension at the hip and flexion at the knee. And all 3 of those muscles are innervated by the tibial division of the sciatic nerve. The 4th muscle doesn't do any of the above. The 4th muscle is the short head of the biceps femoris. Together, these 4 muscles are called the hamstrings because pork thighs are hung up using the long tendons of all 4 of those muscles. So the hamstrings, basically, they extend the hip and they flex the knee, but they can't do both of those things maximally at the same time. That's because full extension shortens the hamstrings, and the muscles aren't going to be able to contract then to act on the knee because they're already too short. And when the knee is fully flexed, then you can get extension, but you're not going to be able to get maximum extension of the hip. A person that has paralyzed hamstrings will fall forward because the gluteus maximus can't maintain the necessary muscle tone in order to stand straight. The hamstrings are hip extensors that are involved in walking on flat ground when the gluteus maximus is not active. The semitendinosus muscle is on the medial side. The semitendinosus muscle is on top of the semimembranosus muscle, so it's more superficial. So semitendinosus, T for top, is on top of the semimembranosus muscle. The semitendinosus muscle is half tendinous, so half of its muscle, half of its tendon. It attaches to the pes anserinus formation with the sartorius and the gracilis muscles. The origin of the semitendinosus muscle is the ischial tuberosity, and then it inserts on the medial surface of the superior tibia. It's innervated by the tibial division of the sciatic nerve. We're going to see that the sciatic nerve, again, is actually 2 nerves, and one of them is the tibial nerve. And the action of the semitendinosus is to extend the thigh, and to flex the knee. So flex the leg and medially rotate it when the knee is flexed. When the thigh and the leg are flexed, the muscles will extend the trunk. The semimembranosus muscle is underneath the semitendinosus. It's a broad muscle, so you can see it on either side of the semitendinosus tendon. The tendon of the semimembranosus muscle divides, and one portion of the division forms the oblique popliteal ligament. The origin of this semimembranosus muscle is the ischial tuberosity, and the insertion is the posterior part of the medial condyle of the tibia. It's innervated by the tibial division of the sciatic nerve, just like the semitendinosus. The action is to extend the thigh, to flex the leg and medially rotate it when the knee is flexed. And when the thigh and leg are flexed, the muscles can extend the trunk. The biceps femoris is the lateral part of the hamstrings. It has two heads, a long head and a short head. They are innervated by different nerves, so injury of one nerve won't paralyze the entire muscle. The two heads produce lateral flexion of the tibia at the knee, which is important in snow skiing. The joint is it's a hinge joint, so it really doesn't have much lateral flexion. But like it says, in snow skiing, when you're making those turns, it will hold that knee in more of a lateral flexion in order to prevent damage or injury to that joint. The origin of the biceps femoris has the long head is on the ischial tuberosity, and the short head is the linea aspera and the lateral supracondylar line. And the insertion is on the lateral side of the head of the fibula, split by the fibular collateral ligament. The biceps femoris is innervated by two nerves. The long head's innervated by the tibial division of the sciatic nerve, and the short head is innervated by the common fibular division of the sciatic nerve. So the tibial and the common fibular nerves are the two nerves that make up the sciatic nerve. The action of the biceps femoris is to flex the leg and laterally rotate it when the knee is flexed, and extend the thigh. For example, when you're accelerating during the first step of your gait of walking. So I want to go over some important nerves from the sacral plexus. Some of them supply the gluteal region, like the superior and inferior gluteal nerves. Some of them pass through the perineum and the thigh, like the pudendal and the sciatic nerves. And then there's nerves like the cluneal nerves that are vulnerable to injury when bone's taken from the ilium for grafting. So we're going to kind of go over some of these nerves. The deep gluteal nerves branch off the sacral plexus and pass through the greater sciatic foramen. The deep gluteal nerves include the superior and inferior gluteal nerves, the sciatic nerve, the nerve to the quadratus femoris, the cutaneous nerve of the thigh, the nerve to the obturator internus, and the pudendal nerves. All of them will emerge inferior to the piriformis, except for the superior gluteal nerve, which emerges superiorly to the piriformis. The sciatic nerve is the largest nerve in the body, and it's a continuation of the sacral plexus. It's so large that it receives its own arterial supply, which is called the artery to the sciatic nerve, and it does not supply anything in the gluteal region, so it just passes by that gluteal region and doesn't have any branches to supply that region. It really is two nerves, the tibial nerve and the common fibular nerve. So here we see the tibial part of the sciatic nerve and the common fibular part of the sciatic nerve. Here we're just seeing some variations of the sciatic nerve. The most common is that the tibial nerve and the common fibular nerve pass underneath the piriformis together and enter into the leg, into the thigh. In B here, we're seeing where they split, and the common fibular nerve will pierce through the piriformis muscle, and that happens in about 12.2% of the time. And then in 0.5% of the time, the tibial nerve and the common fibular nerve split, and the common fibular nerve goes over the top of the piriformis muscle, and then they join back together and enter into the lower limb. The arteries to the gluteal region arise from the internal iliac arteries. So we have the common iliac artery here, and that divides into the internal iliac artery and the external iliac artery. And all the arteries going into the gluteal region then are going to arise from this internal iliac artery. The gluteal veins are tributaries of the internal iliac veins. So they drain into the internal iliac veins, and then the internal iliac veins drain into the common iliac vein, and the common iliac vein then drains into the inferior vena cava. Lymph from the deep tissues of the buttocks follow the gluteal vessels to the superior and inferior gluteal lymph nodes, and then into the internal, external, and common iliac lymph nodes, and then into the lateral lumbar lymph nodes. And then this lymph will flow into the cisterna chyli, and then into the thoracic duct, and then finally will deliver that fluid to the left subclavian vein. Lymph from the superficial tissues enter into the superficial inguinal lymph nodes. For surface anatomy, we want to look at, well, there's a line that crosses the top of the iliac crests. That's crossing the L4-5 intervertebral disc. And then there's the intergluteal cleft, which is inferior to the apex of the sacrum. It's the deep groove between the buttocks. There's also the gluteal fold. The gluteal fold is the inferior edge of the gluteus maximus, and then right below that is the gluteal sulcus, and that's the skin crease just inferior to that gluteal fold. And then finally we have the PSIS, or the posterior superior iliac spine, and that's at, you can see the dimples there. That's a permanent skin dimple, and it's about 3.75 centimeters from midline, and it passes through the S2 spinous process. Two gluteal muscles can also be located and palpated. The gluteus maximus, the inferior edge of that is located right at the superior, is located just superior to the gluteal fold. If you draw a line from the PSIS to the greater superior portion of the greater trochanter, that's where the superior edge of the gluteus maximus will be. And then if you look at a line from the coccyx to the ischial tuberosity, that's going to be the inferior edge of the gluteus maximus. The gluteus medius is felt between the superior portion of the gluteus maximus and the iliac crest. If a person shifts their weight, you can palpate it on the ipsilateral side, so on the side that they are putting the weight onto. The piriformis, if you look at the skin, draw a line from the skin dimple, from the, which is the PSIS, to the superior portion of the greater trochanter, that's where the piriformis is going to be as well. If we look at some more surface anatomy, the greater trochanter is lateral, and you can tell where, especially on women, because of the angle, right where they have the curve on their hip, that's where the greater trochanter is. And you can feel that. You can feel the superior portion of that if a person were to medially and laterally rotate their hip. The sciatic nerve can be found if you draw a line that extends from a point midway between the greater trochanter and the ischial tuberosity. And then it goes down the middle of the posterior thigh, and then it will bifurcate into the tibial and common fibular nerve between the middle and inferior third of the thigh. The tibial nerve bisects the popliteal fossa, and the common fibular nerve follows the tendon of the biceps femoris. You should also be able to palpate the long head and the tendon of the biceps femoris muscle, and you should also be able to palpate the semitendinosus muscle, which is medial. And you should be able to pull the semitendinosus tendon away from the semimembranosus muscle. Here is some other surface anatomy that you should be able to locate. Number 1 is the gluteus fascia that's covering the gluteus medius. Number 2 here, this is the gluteus maximus. Number 3, this is that tensor fascia lata that will attach to the ilio tract. So number 4 here is the greater trochanter, but if you follow that down, it's usually like in runners, in athletes, you can feel a very flat band there, and that's the iliotibial tract. You should also be able to locate, number 8 is the vastus lateralis muscle. You can see the bulge down near the knee. Number 5 is the long head of the biceps femoris. And then if you go further down towards the knee, number 6 is the tendon of the long head of the biceps femoris. Number 9 is the iliotibial tract, as it's going to attach to the tibia. The P stands for the patella. And then number 11 is the patellar ligament just below the patella. Number 10 is the anterolateral tubercle of the tibia. And sometimes, in 7 here, this is the head of the fibula. A lot of times when people are palpating the head, they are putting their fingers too far anterior, and then they're hitting that, that tubercle of the tibia. You have to be on the head of the fibula, you're pretty much straight lateral. And then number 12 is the gastrocnemius, and we haven't gone over that muscle yet. Let's finish today by going over some clinical application. So trochanteric bursitis. This is an inflammation of the bursa on the top of the trochanters. So we call that the trochanteric bursa. The gluteus maximus will create friction over the bursa and then cause inflammation of the bursa, which can be very painful. And usually you can elicit the pain with abduction and lateral rotation against resistance. So you have the patient abduct and laterally rotate their leg while you're resisting those motions. An injury to the superior gluteal nerve will show a characteristic motor loss. And this motor loss appears as a gluteus medius limp. And it is to compensate for the weakened abduction of the thigh. Or sometimes it's called the gluteal gait, which is where a person gets a list of the body to the weakened side. This is also known as the Trendelenburg sign. So we could do it. So the superior gluteal nerve, it innervates the gluteus medius. And if there's injury to that superior gluteal nerve, then the gluteus medius isn't going to be working properly. And so it's going to list, or it's going to drop to the weakened side. So you can test this muscle by doing the Trendelenburg test. And this is where you stand on one leg, have a person stand on one leg, and the side that's weight bearing that leg will descend and the hip will kind of throw itself, that person will throw their hip out to compensate. So they kind of lurch towards the weak side, producing a waddling or a gluteal gait. There is a link here to a very short YouTube video if you want to watch it to see what a Trendelenburg sign would look like. And you can see the gluteal gait where a person is listing to the weak side. Piriformis syndrome is another condition. Piriformis syndrome is when a person gets pain in their buttocks from compression of the sciatic nerve because of the piriformis. The piriformis hypertrophies or spasms, and then it compresses that sciatic nerve. This is seen frequently in people like athletes, like ice skaters or cyclists or rock climbers, where they are hypertrophying that piriformis by the motions that they're doing with those activities. And women seem to be more susceptible to this. And lastly, I just wanted to mention intragluteal injections. The gluteal muscles are a common site for intramuscular injections. At the superior gluteus maximus, at a line above the PSIS and the greater trochanter, that would be a good site for the intramuscular injection because there's a lot of thickness there, a lot of bulk. It can also be given safely in the anterolateral thigh. If you put your index finger on your ASIS and your middle finger on the iliac crest, and you spread your fingers out, the injection would be given just anterior to the proximal joint of the middle finger. And in that way, you would be able to avoid the sciatic nerve. All right, this ends this lecture on the lower limb, the gluteal region, and the femoral region.